So my name's Rob, and I'm here today to firstly say thank you to many of you in this room for your generous donations and giving, which has really afforded us the opportunity to take forward our research. I've been the lucky recipient of the Michelle McGrath Fellowship, which has literally just started, and tonight's an opportunity to take you through some of the program which we're instituting over the coming years. Our research is really focused on microbial manipulation in particularly inflammatory bowel diseases, but there is a broader application of this science moving towards novel therapies. So as a bit of background for several slides, the gut microbiota is a term which applies to the organisms which live within us. We could be better described as a superorganism, is that we are host to many millions of organisms that outnumber our cells by more than tenfold, and they've co-evolved with us for millions of years, and this is the gut microbiota. We are, however, living in an era of what could be described as microbial extinction. We're seeing in developing countries loss of microbes, so not only loss of diversity but actual loss of organisms over time. This is well shown in migration studies where someone moves from a developing to a developed country, and over time they lose microbes, they lose diversity, and that is then compounded over generations. So what could be described as an ecological sort of microbial extinction event comparable to something that would happen in the environment. What is driving these changes? Well, can you guys see? Sorry. We do think that it's more of a Western environmental blanket, so it doesn't seem to be a single driving factor, but a compilation of factors of modern life in developed countries, and certainly diet is a big or a key one of those. When we look at the gut microbiota, many of you would have seen in popular press there is an increasing association with abnormalities of the gut microbiota and disease. These are not just gut-borne diseases, but metabolic diseases, obesity, neurodegenerative and mental health illnesses. Our particular interest relates to inflammatory bowel diseases. I feel like I'm in the way, but I don't know what I can do about it. Shall I stand over there? So inflammatory bowel diseases are a group of lifelong inflammatory disorders. These affect young people. They're diseases, ulcerative colitis and Crohn's disease, and they affect the gastrointestinal tract, but also beyond. So there's rashes and joint symptoms alongside. There is no medical cure, and these illnesses relapse and remit over the course of a lifetime. And for Crohn's disease, more than 70% of patients will have to undergo abdominal surgery during their course. I've mentioned it's a young demographic, so the diagnosis is usually in the second or third decade. But as the illness becomes more common, there are more diagnoses as well later in life. We are seeing rising rates of inflammatory bowel disease in developed countries. Australia has some of the highest rates in the world. It's roughly estimated to affect 1 in 250 Australians as it stands, and perhaps as we go towards 2040, if you extrapolate the figures, it seems to be heading towards more like 1 in 150 or even towards 1 in 100. So it really is escalating. The cost of inflammatory bowel disease is high. The cost is high to the individual, the sufferer, loss of quality of life, occupational and physical disability, alongside the cost to the community, which is driven by biological therapies as well as hospitalisation and surgery. We're sort of now in what has been sensationally described as an IBD pandemic. As described, there are high rates in developed countries, rapidly accelerated rates in developing countries alongside westernisation, and Australia has the highest rates in the world. So why would we consider gut microbial therapies? We know that gut microbes are involved in the underlying cause or the pathogenesis of inflammatory bowel disease. Unfortunately, the current therapies that we have just target the immune system, so they nominally suppress the immune system to stop it attacking the gut wall, and that's associated with side effects, and more importantly, those therapies are incompletely effective, only around 30% at sort of best case. So one of the sort of major vehicles of gut microbial therapy or manipulation that you may have heard of is fecal microbiota transplantation. This involves transfer of healthy stool from a healthy donor to someone with disease with the aim of treating that disease. This is in fact quite ancient science, so it's been used, yellow soup in fourth dynasty China. The Bedouin people of northern Africa in the setting of dysentery would consume camel feces. So certainly it's been around for a while. In the inflammatory bowel disease literature, it first came about in about 1989, where a physician himself wrote a letter to the Lancet saying that he'd been undertaking FMT himself, and it had led to resolution of intractable colitis. To take you forward a few years, so Sam Costello and colleagues, and many of us were involved, was a large trial of FMT and ulcerative colitis, and this was a definitive study showing that we could achieve rates of remission, induction, that means septal inflammation in colitis, which was similar to very expensive biological immunosuppressive therapies. And what's really resounding about this treatment is that it's, when you look at how good it is over placebo, which is just the sort of fake therapy, it really has quite an impact and is as impactful as our most expensive therapies. How else can we change the gut microbiota? Well, we can use diet. Diet is a core element to changing or forming and manipulating the composition and function of the microbes in our gut. These are just graphs, but on that side you can see that even short-term changes in switching between a plant-based or an animal-based diet yield significant changes in what colonies of organisms you have in your gut and the function. On this side you can see very big differences between, in the gut microbial populations between European children living an urban life and rural African children consuming a high fibre plant-based diet. So it really does change the organisms in your gut. As far as therapy goes, there is a world of evolving dietary therapies for inflammatory bowel disease. One of them is the quite unpleasant exclusive enteral nutrition. So what this involves is literally just drinking liquid, exclusively liquid nutritional formulas. So we're talking about things like Ensure without having any table foods for up to 6 to 8 weeks. There are whole food strategies evolving, and that's what our big drive is. Dietary research is hard, and I've discussed it with some of you tonight. Diet is a complex, three-dimensional entity. You cut something out, it's not a single chemical, you're cutting out a whole food class and other things come in. So our research program, just as an overview, involves this microbial manipulation in inflammatory bowel disease. We're lucky to be based here in Woodville, so we're across the Basil Hetzel and the Queen Elizabeth Hospital. And we have a big energetic group of gastroenterologists, dietitians, nurses and scientists, and a growing raft of higher degree students. Just to walk you through our program, so we are exploring dietary therapies, fecal microbiota transplantation, with a view towards developing rational microbial therapies for treatment of inflammatory bowel disease. At the Basil Hetzel and Queen Liz, we're doing high quality studies with our collaborators. We're engaging in cutting edge science, and really what our goal is to help people to develop novel therapies and also mechanistic insights to understand what is happening in inflammatory bowel disease. We can see the trends, but no one has been able to elucidate exactly what's actually going on underneath. In terms of our clinical studies, so from the diet arms, and I'll touch on some of the more important studies, we're doing a large randomised trial of a specific dietary strategy to help people with ulcerative colitis. We are exploring the use of those liquid nutritional formulas and how can we make it better for people. It does work. And we're also looking at the impact of specific nutrients, in particular protein in colitis. From the FMT side, we've just concluded a study in ulcerative proctitis and have found that that's a particular population of people with a short distance of colitis. We're part of a large study in Crohn's disease, which I'll mention. Where we're heading is this holy grail of a combination of diet and fecal microbiota transplantation, drastically change the organisms in the bowel and then fertilise them with an appropriate diet over time so as to engraft them and have a longitudinal change in disease. and then we're looking towards these rational therapies, which I'll touch on. In terms of the diet study, we did a pilot study, which was in fact partially supported by the Hospital Research Foundation a number of years ago, and this showed us that our unique dietary strategy, which was a sulfide-reducing diet, limiting excess protein, increasing fermentable fibre and restricting food additives, was in fact effective in making people with ulcerative colitis better. It settled their inflammation down. After concluding that study, we've been lucky to again gain funding from multi-sources, and we're around a third of the way through recruiting for this large randomised trial, which will really inform us as to the place of this amazing whole food dietary strategy in real world practice. Our next study that we're involved in is a 2-centre study of using fecal transplant in Crohn's disease. This is really exciting as it stands to be a pivotal randomised trial which will show us whether or not it works in this area. Again, we're partway through recruitment and it does seem to be having clinical effect, although we're not unblinded, and we're really excited that this could be something new for people with Crohn's disease. When I talk through these future studies combining these entities, one of the key areas we're looking at is patients with post-operative Crohn's disease. 70% of people will have surgery. The issue is the disease comes back. So you go through this awful invasive procedure and you then have recurrence of disease and future need for immunosuppression. So we have a hypothesis that our microbial therapies will prevent recurrence of Crohn's disease. And so we have plans for a randomised control trial looking at standard of care versus our therapies, and we think this will be quite transformative. Not only are we doing the clinical studies, but we're trying to unlock this sort of complex interplay of things that are happening in terms of gut microbial function. And at the Basil Hetzel, we're setting up a laboratory to test certain elements of the stool, short-chain fatty acids and in particular sulfides, and with our collaborators are establishing a world-class laboratory here in South Australia. The real sort of blue sky stuff here is evolution of microbial therapies. So fecal transplant is a crude vehicle, there's no doubt about that. We're going to use our studies and look carefully at what the results show us, the clinical effect coupled with culturing the organisms, looking at the genes and the function of those organisms. We're then looking towards creating rational therapies. These are well beyond probiotics, which are usually single organisms, which are just derived from either breast milk or milk, or they're sort of not well advanced to a more complex collection of organisms that will have therapeutic effect. We have a commercial entity which is supported by the Hospital Research Foundation Biobank, which is the mission is to really equitable access to fecal transplant, but also to develop these microbial therapies. We want to move beyond donor-derived therapies. That's our current FMT, whether it be in a syringe form or capsules, towards non-donor-derived therapies. And to explain that a little bit more, what we're describing here is culture of organisms from these clinical trials, exploring what their function is in these particular bugs. Then we grow up the bugs together in a bioreactor, so they are working together like an ecosystem. We're growing an ecology of organisms, not a simple probiotic. And then we can put them in a capsule, and we think that that sort of therapy is going to be transformative for healthcare. So I could just finish by thanking you all so much for your support and for what you've allowed us to do, and we're really, really grateful. So I welcome any questions. Thanks.
Questions for Rob? Put your hands up.
When my daughter found out I was coming along to hear you speak, she's in her mid-50s, and she said, "Oh, Mum, could you just find out if there's anything that she's menopausal and bloat?"
Yeah.
And she said, "Is there anything she can do?"
It's a good question. I mean, the thing is, look, I've just mainly presented on the inflammatory bowel disease, but gut symptoms are common, and what's most common is irritable bowel syndrome. I mean, that affects up to 40% of the population. There does seem to be, and what irritable bowel syndrome describes is abdominal symptoms in bloating, discomfort, and a change in bowel habit, which affects us all really at various times. Typically, that can be dietary or psychological triggers driving symptoms, or other factors such as a menopausal phase. But there does seem to be in many people with irritable bowel syndrome a microbial basis for the underlying symptoms. It seems that there is a change, and that's quite well documented in a number of studies. And there is emerging evidence for what we're doing, fecal transplant, as well as dietary strategies for treating those symptoms. So we do think the application of what's being done will be broader than just inflammatory bowel disease, and really addressing that's important. Yeah.
I mean, recognising there's lots of diets out there and protein-based diets, and I saw a reference to excess protein.
Yeah.
What was that? Something particular? Or?
Yeah, look, we do think it's interesting. In our condition, in ulcerative colitis in particular, I mean, Australians consume a vast amount of protein, as high or more meat than anywhere else in the world, only rivaling the United States, and I think we're actually beyond. Probably from a genetic standpoint, we eat far more meat than we've ever been programmed to do as human beings. I don't think meat would have been that plentiful, and this is a very short evolutionary time frame in which our diets have changed so much since agriculturalisation. In ulcerative colitis in particular, it does seem that excess protein can drive the inflammatory signals that we see in the bugs, as well as the inflammation in the bowel wall. It's not just meat. There's a huge amount of protein supplement intake at the moment, and we're surprised by it. Like, a lot of our patients are using protein unbeknownst to us. And so one mention about protein was actually discovering that more and more it is something that could be driving disease activity and causing flares and symptoms. So it is interesting, yeah, because that's the inverse to the Atkins diet and other things like that, which are proponents of just eating fat and protein and no carbs. Carbs aren't bad, because carbs come with fibre, and fibre is really important.
Yeah.
G'day.
I was very interested in your slide between the Western diet and the African diet, which seem to be very, very different colours.
Yes.
Could you please explain quite a bit more the differences in diet between these two?
I mean, this was a study...
If I can have a follow-up.
Yeah.
And the rates of IBD or other gut problems compared to comparing Western and African.
Yeah, that's exactly the point, and that's a great question, observation. So the gut microbial signatures are vastly different, and that study was a number of years ago, so they just were counting the organisms. So they did a particular technique called 16S, where they just look at composition, taxonomy, what's there and what's not. And you can see it is really different, as demonstrated by those colours.
We're talking trillions of
huge,
microbes.
Vast difference. Exactly right. Yeah, real differences, enormous differences in what's there. What's purported to be driving that is the dietary intake of those different populations. So if you do live in a rural African area, you're eating much more fibre. You're eating maize, corn, things like that. Whereas in an urban situation, if you look at a typical Western diet, it's very processed, and you're looking at simple, refined sugars. And protein and meat, and really that's become the norm in many parts. Are there high rates of IBD in rural Africa? No, there's very, very little, and it's similar in our Indigenous population here. There is very, very little inflammatory bowel disease in Aboriginal people living a traditional lifestyle.
So can that provide pointers to?
Yeah, it can. Yeah, it can, absolutely. The issue is that people want to look at a specific organism and just go, oh, there's one. We're used to saying one bug, one disease, like you've caught this, but it seems more complex than that, because it's the community as a whole has sort of collapsed and changed in its composition, and it's lost its function. So when we're talking about microbial therapies, we're not just talking about replacing a single strain or species, and that's why probiotics today are relatively ineffective because bifido and lacto, it's either vaginal or a milk-based organism. It's not meant for the gut anyway. And they're monocultures. We're looking at growing a whole heap of them together. So it's like reinserting what looks like a diverse gut. So, the African type gut, as it were, without the pathogens, put back in. So, yeah.
So that's driving your cultural, your cultures.
That's the culture, exactly. Yeah, that's the culture-based work. Yeah.
Thanks.
No, thanks.
We've all got different microbiomes, so when we're looking to develop your endpoint, your capsule that you were talking about, how is that going to pick up different variations for different people?
Yeah. Is there going to be a personalised or tailored approach to it? Probably. Probably. Yeah, it's a good point. Like everyone's different and you're going to be missing and needing certain things. But I think we don't know. That's why it's such a vast area of exploration across the world. But nominally, if you can get the core elements of what constitutes a healthy gut flora and you can replace that in form of a therapy, the application of it is really wide. And we think it's likely that if you get a collection to a certain number, it's probably going to be restorative for someone's gut, regardless of their underlying population. But I think in time there will be tailoring of that for sure. Yeah.
Is there work being done in other inflammatory conditions with a similar kind of?
Oh, absolutely. Yeah. This is just a huge explosion. If you look at the literature and if you look at the number of registered trials, inflammatory conditions, rheumatological conditions, mental health, autism. We've done a trial in Parkinson's disease. So currently our group, we partner with a number of other people. We can't run every study. You just can't have the time. But where people have expertise in that condition, we partner with them from the microbial standpoint. So there's a lot going on. Yeah.
Yeah, I was just going to ask about the Parkinson's involved. Is that considered inflammatory, the gut aspect of Parkinson's that may or may not be?
Yeah, what's interesting, so Parkinson's,
your inflammatory?
It's probably, you wouldn't say it was, so it's not gut inflammatory from the neurological standpoint. I mean, there are changes there. From a gut perspective, Parkinson's, its first description, James Parkinson's 1812, was a description of chronic constipation associated with a movement disorder. So there is a gut involvement there. And when he described it, he gave them magnesium salts, and that amelioration of the constipation led to some improvement in the movement. So we have done a FMT study in Parkinson's, only a small group of 12 people as a pilot, and that's being analysed now, and there certainly have been changes and improvement in gut function in that group.
We had a question, Robin.
Oh, it was just mentioned, we, as in male and female, from the people that I know that have IBS, the proportion really is women are a much higher proportion.
Yeah.
Is that?
Yeah, that's a good observation. Probably clinically, yes, and probably like the papers would stack up to say perhaps more, but I do think it affects, both genders significantly given the overall proportion of people affected by it. But yeah, I think it is probably women more than men. Yeah.
My daughter has IBS and she has she's got an 18-month-old daughter who has allergies galore. What would you recommend for improving her gut health?
That's a good question. It's actually a common one that we face, not in research but in clinical practice. I mean, probably what I would say would be, I just can't speak highly enough for dietitians and their role for a multidisciplinary approach to management. I mean, I don't think there's a magic bullet therein. I think any therapy for irritable bowel syndrome is a gamut of complementary things. So if there's a psychological basis for symptoms, which there can be, gut-focused hypnotherapy's got good evidence. There's strong evidence for particular dietary strategies. The low FODMAP diet is one of those. Low salicylate diet is another. There are some other over-the-counter therapies without particularly strong evidence, but that are useful. With regard to how your daughter's diagnosis of IBS interacts with gut allergies, that's a really tough one. And I probably can't give a really good answer to that, I'm afraid. But, you know, there certainly are things that, you know, I suspect there is probably a microbial link at some level, but I don't know what the answer is, yeah. But good question.
Any other questions? Thank you, Rob.
Thank you very much. Thank you.
Beautiful. All right. Thank you very much for having me here today. It's wonderful to be here and to speak to you all. And I know that dementia is something that touches all of us in different ways, so I'm hoping that you can all get some benefit from this presentation. So when I finished university, you know, my first degree, I was an occupational therapist, and I really went into occupational therapy thinking that I wanted to work with children. And then I went through my degree thinking I really want to work with children, and then I got my first job working with older people, and I actually haven't turned back. So I've worked with older people in hospitals, in the community, in rehabilitation settings, and just find it really rewarding and a really complex area as well, and really I think something that can really help make a difference for older people. So we're going from the gut to the brain here, and I want to talk about, we have a very negative perception, there's a lot of stigma around dementia, but I want to talk about some of the treatments that work. So I'll, hopefully you can get a little bit of information. Sure. And I do have to say that, so dementia is actually the #1 health fear of older people. So most older people over 60, they did a survey and they found out that about 1/3 of them, their main health concern was a fear about developing Alzheimer's dementia, followed by cancer or stroke. And one of the questions earlier was, is Alzheimer's the same as dementia? So Alzheimer's is the most common form of dementia, but there are actually many types of dementia. So the most common one is Alzheimer's. We also have vascular, frontotemporal, and other types. And younger onset dementia, I should say, are some of the more common ones. So in South Australia, we know that there are about 40,000 people who have been diagnosed with dementia. Nationally, there's about 400,000. But we also know that only about 1/3 to 1/2 of people ever receive a diagnosis. So people are often concerned about coming forward. Often everyone in the family will think, I think mum has dementia, but we don't want to break the news, or what's the point of getting a diagnosis because there's nothing that can be done anyway. So we do think that actually the numbers of people with dementia are a lot higher than that. We also know that sometimes it does take a while to get a diagnosis because people will notice subtle changes in behaviour, but it'll take quite a while before they actually go to the doctor to get those checked out. So the other thing I would say is that we often have this kind of perception that people with dementia are in nursing homes, but we know that about 3/4 of people with dementia live at home in the community and supported by a family or by formal care services. Now, the tricky thing with dementia is that everybody's needs are very different. So we all know someone with dementia. These are 2 people I know. So the lady on the left is my husband's grandmother. She is 104. So this was her 100th birthday taken 4 years ago. And she was diagnosed with dementia about 7 years ago. So she is living in a residential care facility now. She's had a very slow decline. But her needs are completely different to my friend John. John lives in Queensland. He is a very active dementia advocate. So he was diagnosed with younger onset dementia, and he is often in the media doing stories. This was a big bike ride he did around Australia raising money for dementia. Now, John's needs and Ina, my husband's grandmother's needs, are very different. So we really need to personalise care based on what the person's needs and goals are. We have the WHO Global Action Plan for Dementia. We're now almost to the end of those, but it talks about really making dementia a public health priority, about raising dementia awareness and friendliness of our society, risk reduction, about improving diagnosis, treatment and care, providing more support for carers, because without carers we would be lost, providing more information systems and data around the prevalence and needs of people with dementia, and about investing in dementia research and innovation. And the ultimate goal of the World Health Organization is to have a world where dementia is prevented, but also that people with dementia and their carers live well. and receive the care and support they need to fulfil their potential with dignity, respect, autonomy, and equality. And, you know, there are developments in terms of drugs which may help either prevent or not cure, but delay the progression of dementia. But we also know that because there's so many types of dementia, even if we have a cure for Alzheimer's, there's still going to be a lot of people in need. So we really need the best treatment and care pathways available. So we can see here, now you won't be able to see here, but we actually think that probably up to 40% of dementia could be prevented through public health intervention. So, you know, we do have people that have genetic predisposition to dementia, but there are things across the lifespan that contribute to our risk. And if we eliminated all of those risks, we'd reduce the prevalence by about 40% and potentially more in Western countries. So at the start, we can see people with lower levels of education have an increased risk of developing dementia. And then across the lifespan, we can see high blood pressure, obesity in midlife contribute. And one of the most interesting findings recently has been that people who have hearing loss also seem to have, I'm sorry, we just had a conversation about hearing loss, but there's been some recent research that suggests that hearing loss seems to increase the risk of dementia, but we don't know whether, you know, having hearing loss and not seeking help. So for example, if you don't come forward and get a hearing aid, then perhaps you become a little bit more isolated. You're not hearing what's going on. You're not being as cognitively stimulated. Or it might be the other way, that actually someone has some cognitive symptoms and that stops them having the kind of initiative to recognise that they're having hearing issues, to speak to their family about it and to go and get that sorted out. So that relationship is quite new and not really understood well. And then in later life, smoking contributes, depression, physical inactivity, social isolation and diabetes. So we can see that there's different risk factors across different points of our life. So for these people, for people in the room who are in midlife, there's things we can do. For people in the room who are towards later life, there's still things we can do. Okay, interestingly as well, there's been some recent research which has kind of come out. There was a really big paper that was published the other day that said that they were, that, you know, there's this hypothesis that cognition is really closely linked to physical activity. So the more active you are, I guess you have better aerobic fitness, it's better for your brain. The research suggests that the link isn't perhaps as strong as we thought, but there is some good evidence that actual high levels of daily activity are associated with better cognition. So it's not necessarily flurries of exercise, but these autopsies with people showed that there's a correlation between total number of steps over the day and cognition. So we do think that this physical activity and remaining active may enhance our cognitive reserve. So one of the biggest trials around dementia prevention took place in Finland. It was called the FINGER trial, so it had over 1,000 adults, and these were people who were at risk of cognitive decline. And so basically in this trial, they gave them anything they thought helped. So people who received the intervention, they did exercise, they had nutritional counselling, they looked at their cardiovascular risk factors and management, they provided them with cognitive training, and they talked about maintaining their social connections and social activity. And so what they found was, interestingly, those people who were at risk in the control group who didn't get that did experience further decline, but those who got kind of everything, they remained relatively stable in terms of their cognitive function. Now that study, you know, the problem with dementia prevention studies is you've got to follow people up for many, many years to be able to see whether they go on to develop dementia. So the early signs were that this intervention was superior, but whether or not it has gone on to prevent or delay dementia is still being assessed. Okay, so this is really my area. So I'm looking at once someone's diagnosed with dementia, what then? And I was involved in this development of clinical practice guidelines for dementia in 2016. So these were the first clinical practice guidelines endorsed by the NHMRC, and they have evidence-based recommendations for every phase of the illness and in different settings as well. So one of the things we think is that there's really a need for more support soon after a diagnosis. So as I said, it can often take a while to get that diagnosis, and then people say that the experience, the experience is that they go and see their doctor, and the doctor says, unfortunately, you've got dementia. You'll probably get more dependent on people over time. You know, look into aged care services, get your affairs in order, and that's it. But, you know, that's different to many other conditions. If you were diagnosed with cancer, you'd be provided with support. If you'd had a stroke, you'd get support. If you were diagnosed with other conditions, you'd get a lot more intervention. So Marie McCabe, who's the head of Dementia Australia, told the Royal Commission that there's a real breakdown. So if we had a diagnosis with another chronic condition, there's a referral pathway. There's a team of people that are available to you. Whereas people with dementia say that they feel like they're just left. The other thing is that we often know that people live for, on average, 5 to 7 years after a diagnosis of dementia. So that's really a long time to get your affairs in order and just wait. And we know that there's a lot of, you know, positive things that people can do. So this is a common thing that would happen. So I would go and see a family, and Bob has just been diagnosed with dementia. So Bob's family are now concerned about his mood. So they say he's apathetic, he's not interested in things, he's bored, he's grumpy, and he spends most of his time now watching TV. So 10 years ago, Bob had retired, he'd spent a lot of time in the garden, but, you know, he was finding that more difficult. So what the family think that they're doing to help, they think, right, well, let's get Jim's mowing in, let's get someone in, let's keep the garden nice for Bob, while Bob's sitting inside and watching TV. So Bob's then kind of, I guess he doesn't have that environmental stimulation, he doesn't have the physical activity, and he doesn't have that engagement in things that he really enjoys. So as an occupational therapist, I would be saying, okay, well, let's get Bob involved in things again, and how can we do that? Maybe he can't do the mowing, but maybe he can do the pruning, and maybe he just needs someone to be out there with him to get him started. Maybe he doesn't know how to go to the shed anymore and find the pruners because it's quite overwhelming, but maybe if we place the pruners out here for him, you know, that'll get him started. So we're looking at ways so that people can still do the things that are important to them, and that keeps them independent. Okay, so what if we thought differently about life after a diagnosis with dementia? So a lot of people say, but people with dementia can't learn new information. So, you know, why would we spend that time with Bob? So actually some people can, and particularly people with the milder stages of dementia early in the course, they can retain new information. And the other thing is that we're not always about teaching them new things, but we're supporting them in terms of the environment and changing the way that things are done to be able to maximise their function. And the other thing is that rehabilitation is broader than that. So rehabilitation isn't always having an injury and making a comeback or a recovery, but it's really about maximising what you're able to do with what you've got. A lot of people say, well, but, you know, dementia is a degenerative condition. But as I said, typically the duration from diagnosis to death is around 7 years. So we do have a long time to work with people to really optimise their quality of life. And we know that other people with other degenerative diagnoses receive rehabilitation, so there should be equity in that as well. And the other thing is people say, oh, but there isn't evidence, there's nothing you can do. But actually there is evidence for many of the treatment approaches after dementia, and I'll talk about some of them today. And we do need more information and more research about which types of intervention are going to be most cost effective. So one of the studies we're doing at the moment is called Taking Charge after a diagnosis of dementia. So taking charge is, instead of saying to someone, really having their world shrink and say, you know, start to get your affairs in order, start to look for aged care services, take charge is about seeing the bigger picture. So we're working with people within 6 months of diagnosis. We know that within, you know, the first few weeks can be quite an adjustment. However, we also know that some people, or quite often people say that actually having the diagnosis, it was reassuring for them because, you know, they were worried that something else was wrong with them, or they were worried that, you know, things weren't going right. But actually having a diagnosis of a clinical condition can reaffirm, well, you know, I've noticed that something wasn't right and now I know why. But working with Take Charge, we're working with people to see the big picture, to talk about who the person is as a person, to have that attitude that anything is possible, and also talking about having support networks. And so really it's based on patient activation literature. So there's a lot of research that shows that people who I guess have more confidence that they're able to take charge of their own health and manage their own health conditions, those people actually do manage their own health conditions better. They present to emergency departments less, they use less health services because they're in charge of their own health. So this Take Charge after a diagnosis of dementia, now it has been, this particular intervention has been shown to improve quality of life for people after stroke in 3 different studies. So we've just adapted it a little bit for dementia. So this particular research was funded by the Hospital Research Foundation, and what we've done is we've adapted the program for people within 6 months of a diagnosis, and we're looking at people, if they receive the program, do they have higher levels of quality of life, levels of hope, independence, and lower levels of health service use. So we can see here, this is a randomised controlled trial, and people with severe cognitive impairment are excluded, so it's people in the mild phases. So people come in, most of our participants come through a memory clinic and the doctors refer them to our trial, and then they're randomised to either receive this Take Charge intervention, which involves 2 consultations and this patient activation kind of approach with a health professional, or they go onto a waitlist group, so they can be, they don't get anything in the short term, but then they're offered the program later, and then we assess them at 3 and 6 months. As I said, we've got 2 consultations with a health professional. In this instance, it's a nurse. The intervention is guided by a booklet. People talk about their overall hopes and aims for the next 12 months. There's a lot of people who receive a diagnosis and think, like, we've always wanted to do a trip to Darwin, now's the time. Or, you know, we've always wanted to, go and visit the open gardens in Canberra. Or, you know, what I've always wanted to do a cooking class. Whatever it might be. We're really talking about people. This is the opportunity to do the things that you've always wanted to do. It's not too late. We talk about people's main fears. We talk about what people's best day would look like and their intentions. And then they break that down with their health professional into, you know, what are we going to do as a result of this conversation? So what actions are going to be taken? So we've so far recruited 143 people to our study. We need 174, so we're just in the final stages, and we're just planning to finish recruitment in the next couple of months. And then we'll be continuing to do our assessments for a further 6 months, because we're looking at people for, you know, into the longer term to see whether there's a longer lasting effect of the intervention. And then we'll do our analysis later this year. And the other thing I guess I wanted to talk to this group about, you know, you're all very involved in health, and it's fantastic that you support medical research. A lot of the work I do as well, I'm working with members of the community and consumers around really guiding the direction of research. So it's important to contribute to funding for research, but it's also important to be the voice that really talks about what will make a difference. So, you know, you guys know what different health conditions you have, or your families have. So it's really important to hear directly about what research would make a difference to you and how that should be done and how to share that information. So I've got some business cards. If anyone wants to be involved in my research about dementia or ageing, please let me know, and we're always looking for people, whether you're a family member, whether you're worried about yourself. Any questions or discussion?
That was fantastic.
Oh, thank you.
I'd just like to say that my husband was diagnosed with dementia late last year, and he's under a geriatrician and on some medication.
Yeah.
Yes, it is quite challenging at times, but you know, he's still able to make his own appointments.
Yeah.
And he functions
Yeah.
really well.
Yeah.
At this stage, but there are times when, you know, I think, oh, you know, he would have known, he wouldn't have asked this question.
Yeah.
But I mean, he's under a geriatrician.
Yeah.
And has medication. So,
Yeah.
and the test that he went through, was amazing, really.
Yeah.
When they asked, where were you born and where did you live and where did you go to high school and what was the name of your headmaster and how many children do you have and what ages they are, and then to draw a clock face and to put in the time of the day. And the other one was this kind of cube that was interlocking, and he had to do that. Now, he did all of that perfectly.
Yeah.
He was a banker.
Right.
Now, whether that, and to count from sevens from 100 down.
Yeah. Well, that probably came naturally to him, didn't it? So we definitely noticed. So, well done, partly for being here as well, because it's very important for you to keep up your social networks and to keep up, the things that you like doing. And also for him as well, for you to recognise that it's really important for him to be independent and keep doing as much as he can. So that's fantastic. We do know in the clinic, so dementia is a clinical diagnosis, so part of that involves cognitive testing. And we know that people, we expect that people who have higher levels of education or come from very stimulating jobs in the past, they do naturally perform better on those tests. So often we'll get people who can have quite significant, you look at their scans and they're quite significantly impaired, but their performance on these tests is amazing. And we kind of talk about cognitive reserve. So the more you can do for your brain to kind of challenge it and have it as, I guess, as strong as possible, the more cognitive reserve you've got to cope with any changes in pathology to your brain. So that's quite common. We'll have people who are, have dementia but score perfectly, almost perfectly on those tests.
It's kind of amazing because we went to a cousin's lunch and he wasn't sure which cousin belonged to which auntie and uncle.
Yeah.
Those type of things, yes. There you go.
Thank you. Yes.
You've talked about the many forms of dementia.
Yes.
With vascular being one.
Yes.
Would you talk a bit more about that and whether there are any interventions for vascular dementia?
Yes.
Taking cardiac, for example.
Oh gosh, I'm not a medical doctor, so I'm really the wrong person to ask. You'd have to go and see a specialist. But I do know, vascular dementia. It's really important to get that real cardiovascular workup and see what's happening. And management of hypertension or high blood pressure is really important in vascular dementia, but I'm not in a position to give advice on that aspect, sorry.
Thank you.
I really liked your comment about when somebody has cancer and, it's all poor you and there's a whole team around them to support them, but it almost seems like in our society we don't value our elderly people as much as we possibly could, and it's, as soon as you're diagnosed, it's, as you said, off to the nursing home, off you go.
Yeah.
See you later.
Yeah. Yeah, and I think, the Royal Commission really kind of shone a bit of a spotlight. We haven't had a great response to the Royal Commission in terms of change. And it's really difficult. And, we talk about the need for more intergenerational programs because people go to a nursing home, and unless you're a visitor to that nursing home, you really don't see a lot of older people with more severe impairments in our society, do we? So, there's talk about, the old people's home for 4-year-olds and having more exposure to older people so that we don't have that stigma, but we also have a greater sense of, empathy and the needs of older people. And more investment because, we all see, pictures of the food that's served and, I kind of think that actually a lot of high schools do work experience. Well, wouldn't it be great if they were doing some, spent a day in residential care to understand, what's ahead of them, and that might help kind of, build a more understanding and need for investment.
As an OT, you looked outside of the box and said, well, look, let's put the pruners by the door. For, I suppose, persons who have dementia in the nursing home, it's a bit more difficult for them. So the use of media now, like say for a farmer who used to be out on the farm I'm hearing stories of them using digital media where they can use that device. What's your thoughts?
Yeah, absolutely. So we've done some work in residential care on a couple of different programs, including the tailored activity program. So, one of the challenges is that in residential care, they'll often have an activity program. It might be, a quiz or a stretching group, and it's kind of a one size fits all, which I appreciate given that the staffing is very lean. But we've done some work where we're working with individuals and finding out what's of interest to them, what's familiar with them, and media can help do that as well. So for some people, I was working with one man and he used to be a mad jigsaw enthusiast. And so I was like, okay, well, he's struggling with these bigger jigsaws, and I'd seen this app where you can actually get a jigsaw and you can customize it to something that's of interest to them, and you can customize it based on number of pieces. So I was like, okay, well, let's try something that's 9 pieces and it's, got a picture of the garden, which is what he's always liked. But having it transfer to the app he couldn't carry that skill over. So he wasn't able to transfer that jigsaw skill. So I do think media is fantastic in terms of what it can bring, photo albums, videos, you can have almost whatever you want. You can watch an opera in Vienna, you can, in virtual reality, there's so much that you can do. But I think sometimes, some of those things do get lost in translation. So it's really a trial and error type situation. But yeah, aren't we lucky? And now, you can FaceTime or you can, speak to relatives interstate much more easily.
There's various forms of dementia.
Yes.
Are they all as bad as each other? And are they often correctly diagnosed with a specific type of dementia? And
yes.
Is it important to diagnose it correctly?
That's a very good question. It's sometimes hard to tell. Usually a specialist or a geriatrician will indicate whether it's which subtype it is. It can be important to know because there's some drugs which are bad for some types. So Lewy body dementia, for example, you have to be quite careful with the drugs that are prescribed. In terms of worse, I think people say that, people with frontotemporal dementia can be harder to care for because they can be quite disinhibited. And that can mean that they might behave inappropriately in a social circumstance. So family can be quite concerned about that. And the trajectory of decline for the different dementias is slightly different as well. So definitely, it is useful to know which subtype, and usually a specialist will tell which one that is. Yeah. Generally, still, they all have about 5 to 7 years between diagnosis and death, but yeah, the trajectory and the symptoms can be different.
Would you talk a bit about musical therapy and whether that's a
yes.
useful thing in dementia?
There is Yes, there is a lot of research into that. There's been some great shows on TV which have shown people, who can not feed themselves anymore, but they can still play Mozart. So there's definitely centres in the brain which hold on to that musical memory. There's some really good research that music therapy is beneficial for quality of life and also for management of challenging behaviours. So people that become agitated very often or people that are apathetic and disengaged, music therapy can really be beneficial. Interestingly, the music suggests that it's actually more beneficial to listen to music than to participate in it. So there's a lot of research studies where, for example, they'll get a group together and everyone's given a musical instrument and you're all listening to the same. But actually the research shows that if you listen by yourself with a personalised playlist, so the stuff that you really want to hear, that seems to actually be more effective than these kind of group-based programs.